When we're looking at patients with diffuse large B-cell diagnoses, we often see about an average, just in 2019, of about 74,000 patients were diagnosed with non-Hodgkin's lymphoma. In addition, of those patients, around about 33 or about one-third of those, usually it's around 32%, actually have a diagnosis of diffuse large B-cell lymphoma. So if we're putting that picture into play, that's who we're treating with first-line therapy. Now, when it comes into the case of relapsed or refractory-based disease states, that's when we're seeing patients who may have a potential for a curative-based evaluation will actually relapse during that period of time. So there is a potential for curative diagnostic. However, those patients who are relapsed often have a poor prognostic outcome. So again, they actually may have a higher percentage in terms of relapsing, also in terms of a decreased overall survival as well. So looking at that picture, really addressing at what the outcomes are tied with potential options for therapy, we're limited at this point. So there is clearly a niche for utilization in these patient populations. In fact, one of the clear determinants that we have to address really upfront when we're looking at the team, really addressing what potential for therapies there are in that relapsed refractory setting, is going to be the discussion of being transplant eligible and also transplant ineligible. And that really distinguishes what we can do. So for patients who are transplant eligible, these patients will then actually go on to a further treatment-based disease conditioning regimen or regimen for treatment, and then go on to a autologous stem cell transplant. In addition, those patients have different options available to them based on their current condition. When we're taking a look at transplant ineligible, these patients are not able to go to transplant. They may have higher comorbidities in other areas too. Older age, and again, we'll probably touch upon this a little bit more, they have a limited option for treatment. And so we really have to delve into what they can tolerate first off, and then also what provides the maximal benefit for those patients. So really setting up this picture for our patients looking at that relapsed refractory setting in diffuse large B-cell area, we actually have a limited number of options in some of these transplant ineligible patient populations. There have been some new treatment options currently being approved here recently. We have seen the utilization of polatuzumab in the combination of bendamustine and rituximab as the backbone, showing efficacy. And really in these cases, we're utilizing the polatuzumab based on CD79B based binding. And we do know that about 95% of those B cells do have that expression of that antigen on top. So really having that membrane domain allows an antibody to bind, and thus the polatuzumab can deliver its payload for killing off those cells. Really, that's the additional utilization here. It's very clear in its indication and also powerful in terms of its outcomes for treatment as well. So the polatuzumab has several benefits in this patient population. Now, we do have to worry about, again, side effect profiles, addressing other areas as well, but the outcome has shown a clear evidence of utilization in this patient population. So we're looking at a very high potential of utilization in this patient population and treatment. With the PBR, we do have to address several side effects. Again, we've seen a higher incidence of peripheral neuropathy in these cases, so we do manage those patients appropriately. And also with the rituximab, for that first or second time infusion reaction, we do a great deal of detailing out pre-medications, making sure we align with our patients to ensure continuous treatment during their period of treatment as well. So we're always actively looking at or engaging in what that treatment option is based on the outcomes, which are actually relatively good in the PBR data for treatment with the polatuzumab arm, and also making sure we mitigate side effects for continued treatment, which actually only improves outcomes in these patient populations.